are you going to start?
No, what's the slide about?
Did you comment back?
Of course I did.
Okay, we are on.
Hi guys, thanks for joining Essence of Medicine. Today we're going to be talking about pain protocols.
What are you going to start?
My name is Amanda Armagas.
Oh, wait. Okay, we are on. Okay, so let's start it again.
Hi guys, thanks for joining. My name is Amanda Armagas. This is Essence of Medicine. Today we're going to be talking about pain protocols.
And this is for Essence and Dr. Bassi. And you see our two social media addicts back there that even in the podcast, they have to be on their cell phone. So
I went to your live stream.
Your kid is kind of cute.
I commented. No, I commented. That was me.
Oh, come on.
I said, yeah, I commented on this live stream.
You guys are twerps.
That's actually pretty classy.
Hype myself up.
That's pretty classy. Okay, so introduce yourself, guys.
Oh, hi, my name is Dr. Aya. I'm an ortho spine surgeon. No.
Sorry.
Go ahead.
That's Dr. Aya. She's way cooler than me. She's a spine surgeon. I'm Mike. I'm a physician assistant.
I think Dr. Aya might be our coolest surgeon here.
What? how did I went down the ladder so
It's
fast?
based on looks.
Yeah, sorry.
Okay,
Typical.
now pain. That's what you're just causing me right now. What is the worst pain, Amanda, you had ever in your life?
Well, I really haven't had a lot of pain. I think my worst pain I've ever had is emotional.
No, I'm talking about, yes, we know that the emotional pain can actually aggravate physical pain and vice versa. But let's talk about physical pain.
One time, my worst pain I've ever had would be when I broke my toe.
No, bro, wow, you are pain-free.
Yeah, I really
Yeah,
haven't had like a lot of
good.
instances. Oh no, when I got a concussion in hockey was my worst pain because I had a really bad headache. from
Yeah, yeah. Takaya, what was the worst pain you ever had?
Childbirth before the epidural.
Really? That is generally considered
a
the
10.
standard 10 of 10.
That's a
You know, that Michael, what about your worst pain? And then explain to us what that pain scale is. Probably everybody knows that, but go ahead.
My worst pain, I think, was actually a really bad contusion I got. Yeah, the day I joined Inspired Spine. And, I got a really bad contusion in a soccer game, and actually I went to the ER later that night, and they were thinking I might have compartment syndrome because my thigh had swollen up to like 1.5 times what it normally was, and it
Compartment syndrome as well is considered
That's a 10.
10 of 10.
yeah, it was horrible. I couldn't sleep, and I had trouble getting out of bed because I was like losing function in my leg. They determined it wasn't compartment syndrome by definition, but it was close, and it just, yeah, I needed to take Vicodin to fall asleep. So
What's up?
You have a TikTok viewer that says their worst pain was when they broke their thumb in a school fight.
Wow, that is
Oh.
dramatic.
what about the other
Broken
guy?
bone. Okay, we have it now. Broken bone generally as well is considered 10 of 10.
Mhm.
Now, in childbirth, obviously, I guess people have a good understanding why it's painful, that painful when something that big coming out of you.
Mhm.
Compartment syndrome is because literally a part of your muscle is suffocating itself, built a lot of lactic acid. And obviously broken bone, the periost, no, not the bone, but the periost of the bone is extremely pain sensitive. So, and all of that sort of identified to us this pain scale, 0 being no pain, 10 being worst pain you had in your life. And what is the pain of, describe, Michael, to us, this pain of 3, 5, 7. What would you understand under those kind of pain?
I would probably say a 3 would be you stub your toe, maybe not break it, but maybe stub your toe on the couch a little bit. It hurts, but it's not nothing like Tylenol can take care of it. Or
Exactly,
something.
that's the point. If Tylenol or ibuprofen can take care of, it's usually considered less than 5.
5 is like you stub your toe pretty bad. Maybe you have like a little bit of a hematoma under it, maybe sprain a ligament. It's Tylenol or ibuprofen takes the edge off a little bit, but it's still there even despite that.
Yeah. So I want to show you something.
Okay, hold on, you guys. Shock warning for those of you watching this.
Okay, shock warning. Well, yeah, sure. Or let's go back there. Then I have to stop sharing and then go there, bring that here. Yeah, we should do somehow that. So now, anybody of you has any doubt about that this pain is 10 of 10? Okay. Well, this is too much work, changing the screen. Okay, I don't like this right now.
Help you.
Really?
If you click zoom up there
Okay.
on the top one.
Okay. Now let's go back. I want to show you a few slides that make you understand what we are talking about here. Okay, here we go. So does anybody has a doubt that this is a 10 of 10 pain?
No.
Not
Would
a doubt.
not a doubt. Would anybody of you hesitate to give this patient narcotic, most strongest kind of pain medication, and so on and so
With no
forth?
head injury, right?
Huh?
With no head injury.
Even with head injury? Would you? If this patient is in pain, is screaming in the ER.
Oh, it is screaming
even-
in the air, that's fine.
Yeah. So, but you wouldn't doubt or hesitate to help this patient. Now I'm going to show you this picture. With this picture, your threshold to give the patient pain medication is a little lower, meaning, I'm sorry, a little higher, meaning that it's more likely that you hesitate to give this patient. But if you are, what we do is like compartment syndrome, look at the leg is swollen, and your threshold is already different than the first patient, right? It's different. That's all what it is. Now, but if you look at that, then again, no problem. You have a broken leg. I'm going to give you pain medication. But what about this one? This is inside of you. This patient does not look like the first patient, but what about if I would tell you that this patient have the same amount of pain in the back than the guy with the broken bone? Because the periost, if you remember, the discs are gone, bone is grinding the bone, and I have had that I could not move an inch. I have myself back pain. So the problem with this is it is inside. You don't see that. And many of these patients, they look like this little old lady here that you don't see in their, you don't see the pathology externally. But I'm not going to run this thing for you, but you can go and watch it. This is online. What I'd like you to know is that it is, this patient go for years sometimes before anybody is willing to help them. So I'm going to unshare this now again and bring back our faces back on. Now, Natalia, why is it that the people with back pain go sometimes tens of years before anybody, start helping them? What do you think, what is the problem there? Why do we hesitate to help these patients?
I think it depends on the way that they access the healthcare system, and then it also depends on how comfortable their provider is in treating the source of their pain.
Yeah.
And also what their pathology is.
Yeah, well, did you know that still in 2023, I have this discussion with some surgeon that we should not be doing surgery for back, just for strictly back pain. That if the back look like what we just showed, that the disc is gone, bone is grinding the bone, we still should not offer them surgery. No, well,
Why do they say that?
like, oh yeah, what do you think? Let's be the devil's advocate. Let's have a debate here. Why do some people say, don't help those patients with the surgery? These are good people, by the way.
I think the general consensus is that there is, whenever you evaluate somebody for surgery, you have to look at the risks and then the benefits. So with regards to the risks, most of the traditional open approaches do have high risks, especially in the elderly population. And then with the benefits, traditionally in literature, back pain, isolated back pain hasn't shown as much benefit as radicular pain with surgical intervention.
So the risk versus benefit is the reason
Mhm.
that many of our surgeons, they don't give even the patient the option that they go from surgeon to surgeon. They are told, I can't help you, but they are not given any alternative. They are just saying, I cannot help you. And what do these patients do though when it comes to that? They get obviously
Injections, different types of treatments with spine pain doctors, oral medicines.
until recently, we made them to narcotic addicts.
Yeah.
Now the system has changed and we are much more cautious these days, but this is just a recent development. So 20 years ago, even 10 years ago, this would have been people who are literally get like tremendous amount of narcotic to just go through their days.
Yeah.
Now, Michael, imagine the pain you told me that you're 10 of 10. Imagine it's not just 1 day or 2 day or week. Imagine that's going on for 10 years.
Yeah.
What would change in your life if you had to go through that pain for 10 years? Can you imagine that?
I think everything in my life would change. I think I'd probably start losing hope. I'd be depressed a lot of the time to just deal with that every day. I was losing a lot of sleep when it first started because it hurt so bad. And I actually did have to be on narcotics for a short period of time just so I could sleep because of the pain. So I can't imagine dealing with that for long. I dealt with it the pain was probably 3 or 4 days, and then the swelling took a couple weeks, but overall it went away, and here I am, happy as always.
Yeah.
So
But what about, I told you that some of these patients, they tell me if that's all what it is, I don't want to live. Can you imagine that somebody can become suicidal with this kind of pain? Now, having said that, we help them in sometimes in different ways. Still, narcotics are part of our pain management, but we don't do chronic. At least I'm hoping that we don't do chronic narcotic management anymore. But talking to one of our specialists, he said there are some people, they just need to be on some level of narcotic and they're functional. They're not they're addicted in the sense that you and I understand of addiction, but they just need some level of narcotic to be functional. So what is our function, Dr. Aya? You and I are provider, and obviously Alyssa and Michael's are provider as well at a different level. What is our job as provider, as physicians?
To help patients,
To
to treat them,
to help them, and to make their life better. Is it if their life is better with certain amount of narcotic, are we going to withhold them from them? If it's really better for their lives, risk versus benefit, to be on narcotic, is it our job to say, I want to make you drug-free, but in 10 of 10 pain, or are we justified to give them narcotic?
I mean, there is always a justification to give
Yes.
narcotics.
So, and that is what most of pain specialists, that like Dr. Schultz, who's the highest pain specialist, says, this hype has to stop. That we cannot this hype has gone from one
extreme.
extreme to another.
Pendulums.
Yeah, now it was a time that we would give the narcotic like candies.
Mhm.
And now there's my patient, a month after the surgery, have gone to ER, and the ER doctor is calling me, say, I'm not prescribing narcotic. I'm not going to risk my license. You see, this is craziness. Like 1 month after a big spinal surgery, are you doubting that this patient is in pain? Now, for everybody, remember the first picture we put on. If you don't doubt that patient is in pain, you cannot doubt that the patient with the spine surgery or with a spinal condition is in pain. By the way, we are mostly talking about the spine because this is a big deal. By the time you're 70 years old, there's only 2% chance you don't have spine problem. So it's in for all of you. And this is something that we generally have to deal with, all of us, especially in our profession. But I don't want to do most of the talking. Now, let's say talk about the pain. Michael, why, or actually let's start with Amanda. Amanda, why do we have pain? What
Well, we
is
have
pain?
to have pain so we know that something's wrong.
I liked how you said that. And there is a condition that the pain receptor, genetic condition that the pain receptors are destroyed. That condition with the pain receptors destroyed, it's a hereditary analgesia, it's called. Have you guys heard of that? You have? Tell me about it. What have you heard about that that condition?
So what I've heard about it is that people don't realize things are going wrong. So then they end up getting really bad tissue infections because they don't feel like they're developing an ulcer, or they'll touch a burner and leave their hand on it because they don't realize they're getting burned until they just literally look at their hand. Or they'll break a bone and keep walking on it, and they just never know anything's wrong. So it's very dangerous because they just don't feel any pain at all.
They do
Yeah.
more damage.
And I'm going to share it on our screen here. We have to find another solution that we don't have to go back and forth like that. But this is the condition that we are talking about. Life.
And one correlation we could actually draw to that is with diabetes, when the small nerves in people's feet
Yeah.
get destroyed. And for you and I and everybody in this room, we feel a little discomfort in our foot and we shift a little bit. But if you have diabetes and your nerves are destroyed in your feet, people don't know to shift, and they'll stand the same way until they develop ulcers, and they can get infected and cause a lot of problems. And that's why so many diabetic people end up with amputations.
Yeah.
I actually never knew that. I was
And
wondering.
this is a child with this condition. By the time they are usually the small, like 9 years old, 7 years old, they have lost the tip of their digits. By the time they are teenager adults, most of them, they have only stumps for arms, hands, and fingers.
Why is that?
Because they injure it. They don't learn from, like, why don't you grab in a boiling water?
Yeah, because I know it's hot, but so they don't feel this.
So they don't learn, and they keep doing things that are dangerous little by little. By the time they're adults, they have stumps for hands.
So like Amanda, if you had like a cut on your hand and that you would purposefully, not even without thinking about it, you wouldn't mess with it. You'd like change the way you hold things, and you change the way you open a door and touch things and wash the dishes. But those people have no idea. So
I
they keep
see.
damaging it little by little until it's
Yeah.
so bad that they
So
lose.
pain is what protects us.
Yeah.
Pain is necessary. Without pain, we wouldn't live long. Pain is what keeps us intact. So pain is necessary, but at what point did the pain, and that I'm talking about acute pain, at what point the acute pain turned into a chronic pain that what we see often in a human society, that it's debilitating, it interfere with your life and so on. So, Tagai, you want to describe what the difference is between acute pain and chronic pain, or what we are talking about here?
So I think the essential difference is the intensity of the pain and then also the time. Different, depending on what you're talking about, there are different definitions, but I think for us in general, something greater than 6 weeks to 3 months is when you usually transition from acute to subacute to chronic pain.
So and once you're in chronic pain, what's the next step, would you say? Like if you're having chronic pain in your hands, it's going from acute to chronic, do you then go see a doctor or should you go see a doctor while it's still acute?
I mean, while it's still acute, but for example, when we talk about back pain, most people, 80% of the American population will have an episode of back pain that results in them seeking medical intervention. So that could be going to the ER, their primary care doctor, some sort of provider, right? But most of those people don't eventually need to have surgery because it's an acute episode and then it gets better. But then some of these people will actually then progress on to chronic pain. So the provider treats the acute pain, usually with muscle relaxers, physical therapy, etc. But if it persists, it doesn't get better in 6 weeks. At that point, then usually they come and seek additional.
One of the fastest and most sure way to make acute pain to chronic pain is, what do you think? What's the safest way if you are evil, Dr. Evil?
Amputation?
No.
You're very evil.
No, you are very evil.
You have pain in your hand if you.
No, but I'm saying you are Dr. Evil and you want somebody to have chronic pain after they have episode of acute pain. What is the safest way to make somebody with the acute pain a chronic pain patient? Most of the studies show if you don't treat the acute pain, that's the safest way to make acute pain to a chronic pain. So let's come back to our patient. Obviously, they have acute pain after our surgeries. If you don't treat their pain properly, you are almost guaranteeing that they will turn into chronic pain. Do you know why?
Is it because the brain kind of like,
I like where you're going.
the brain recognizes the pain and says, don't let this ever happen to me again. So it forms those deep pathways and keeps reminding you.
Quite well understand those pathways. And our nervous system is based on those pathways. Everything we do is based on that. Things that are reinforced in our brain, the paths are stronger, more axonal, more connections are developed. Things that they come and go, those pathways are not developed. Now, if you let somebody with acute pain to reinforce those pathways, so we quite well understand what those pathways are. I'm a neurosurgeon, so Dr. Aya is excused not to know that, but I have to know that it's called Labbé circle. It's a pathway that is in our brain, goes through certain areas. One of those connection in that pathway is the what we call the anterior part of the cingulate gyrus. And I'm going to show you a picture of that, if I can find that. And that part of the cingulate gyrus, I'm going to just bring it down here. And again, we are going to have to do a better.
You could put the zoom there.
Yeah, but then they don't see ourselves. Yeah, let's see here. I have to go back and forth here. So this is the brain midline section. One of those pathways goes through what we call the cingulate gyrus, and then the subgenual part of the cingulate gyrus here is corpus callosum, that's its cingulate gyrus here and here. Just in the last 10, 20 years, we understand this is a major part in our emotional response to the pain, to create those pathways that we talked about. So when I was in my residency, we would poke a needle in and heat it up and poke a hole here. And that was enough to break the circle, these pathways, and break the emotional response, because pain is a sensory. When I like touch you, you feel it. Pain by its nature is nothing but a sensory, but our emotional response to pain is what makes the pain different. And you can break that emotional response by putting a hole either here or here. There's research going in both directions by anterior part or the subgenual part of the single charge, you can break that. Like we would burn that area and the patient would wake up and say, how bad is your pain? 10 of 10, let's go have a coffee. But so obviously somebody during your childbirth and during your compartment syndrome, you weren't thinking about having a coffee.
No.
So, but this patient, you break that emotional response to the pain, because obviously at this point, we know pain is it's a false alarm. It's not really, nothing is broken, nothing is going to kill you, but the nerves are still shooting that pain, that pathways are established. By the way, once those pathways are established, that pain to them is as real as your pain. These are not people who are pretending to be in pain. For them,
No, I want to lift my hand. So does that affect all pain from the entire body, or can you target like specific
chronic pain.
locations?
It's all chronic
It's only
pain.
okay.
It's all chronic pain. All chronic pain, doesn't matter where it's come from. It is.
But you
has
still
been-
have protective sensation like from acute pain.
Yeah, that's the chronic pain. And see, acute pain is a bodily response to a external damage, aggressor. Chronic pain is a pathways within your system. Either that is a internal peripheral nerve system or internal central nerve system. So see, you would put that fire out, right? We understand how it works. This is acute pain. But I'm just going to go down and see, do you see that house on fire? No, it's not a house on fire. It's just your brain thinking that this is a house on fire, but your body behaves the same way. At the end of the day, all pain is in your brain. How do we know that? Because once you put your brain out in a general anesthesia, we can cut you open, take your heart out, put a new heart in, cut your bone, realign it, and so on. All pain at the end of the day is in your brain, in your head. So stop telling patient that their pain is in their head. Everybody's pain is in their head at the end of the day. So, and we understand it quite well, actually, how those pathways work. And we know how they work outside of the central nervous system before they get to our central nervous system, which is the spinal cord and the brain. And we understand as well how they work inside of the nervous system. We have medication that attack that pathway outside of our nervous system, and we have medication that attack those pathways inside of the nervous system. Are you familiar with those medication, Michael?
So inside the nervous system, I think of things like gabapentin, Lyrica, duloxetine.
Now, let's not mix them all together.
Okay.
Let's go back, try it again. Things that are outside of the nervous system are depending on two pathways. Again, we understand them, the prostaglandin pathway and so on and so forth. And those are generally, what category of medication do we have, Dr. Aya, to address the pain?
For the prostaglandins?
Yeah, well, no,
NSAIDs,
generally we have two categories of pain medication, right? Non-steroidal and the narcotic, right? That's two general categories. Most of the non-steroidal, they attack the path that is creation of the pain outside of our central nervous system, because there is actually a process. One factor, one process, like I poke a hole in you, causes a chemical cascade that produces one biochemical substance after another, and there at many levels we can attack that. I'm not going to put it up there. It is in this presentation. That may just confuse people, but like aspirin, attack it in a different way, like than Tylenol or ibuprofen or Lyrica or all the Celebrex or all the other. Then we have the central way of attacking that. What are the medication that attack centrally the pain pathways?
Well, that's what I was thinking gabapentin was.
It does, but in a different way. Let's go to the main ones. What did they give you when you had your compartment syndrome?
Vicodin,
What is it?
an opiate.
An opiate. That means anything that works as a medication, that means your body has a receptor for that. So what are those receptors called?
The mu receptors.
No, the mu receptor, but endorphins
Mhm.
receptors, right? Endorphin is our internal morphine production. It's actually a protein. Now, man,
And you get it from running too.
yeah, you get it actually.
Exercise.
Yes, you do. Actually, it's very true. Amanda, isn't it unbelievable that nature created a molecule that is similar to our internal endorphin?
Mhm.
And why would a plant poppy create a substance that has morphine in it? Literally, morphine comes from if you injure the poppy,
You make
Well,
a slit in the poppy and you get the.
that
stuff
resin.
that comes out.
that's morphine or opium, which morphine is the substance that's why would poppy do something silly like that?
Well, you always say nature tries everything.
No, but why would poppy create, if it's injured, create
To make,
opiate?
probably other animals don't like it and then.
It's bitter, yes, but
yeah,
that's not
and
the thing.
Then it doesn't get eaten.
No, but yeah, but it doesn't get eaten. But why would somebody? I guess some people do want to go and eat the poppy and so on because yum yum opiate and morphine
So
and
that
so on.
it can
But what happens?
reproduce more, or
What happens if you take opium? What's the first thing it happens?
you feel really happy.
Sleeping.
Sleepy. So if you eat the first one, you don't eat the second puppy.
Mm.
Does that make sense?
Has-
Nature, you
Short
pass
term,
out,
It makes sense in short.
and
term.
if you eat too much of it, you die. Right? So nature protect itself. Now, nature puppy, the poor puppy never thought that there are some college kids in US. They
It
go-
didn't start in the US, did it?
no, it
People
did not.
drinking coffee?
No, it
Yeah.
started actually all over the world, the Middle East.
Middle East.
That's where it started. But nature didn't think that we actually get a joy
Yeah.
of something that is supposed to be a toxin.
Mhm.
I don't want to go too off topic, but what about marijuana? I know they use that for pain in some areas.
let's
Where
so-
does that
Sorry.
fall?
Okay, let's go to that. We talked about the not central pain management or pain medication, which is non-steroidal, and there are lots of them. They address it at different level. We talked about the central one, which is the morphine and opiates. Now, the brain is much more complex than that.
Mhm.
We can modulate the pain receptor or pain pathways in our brain. Remember, we can put a hole in it, but even better, we can modulate it. And we call them pain modulators, like
Okay, when you say
gabapentin.
modulate, what do you mean by that?
So imagine that, if I poke a hole in you, you have a pain, but if I distract you, like somebody else is doing some fantastic dance move, you're so concentrated on that I poke a hole in you, you don't even notice.
Mhm.
People who go to war, they see it all the time. They're so focused on the war that they have huge holes in them and they don't even notice that. That's as well in the brain. So they are naturally modulating their pain internally to suppress it. And there's lots of those medication. Gabapentin is, for example, one of them
Mhm.
that changes the threshold for the nerve to shoot signals. Or marijuana or cannabis or THC, the same, is a pain modulator. Antidepressants are pain modulator. Pain causes depression, depression causes pain. For a reason, it's a pain modulator. For that reason, when we do a surgery and we actually we modulate the pain with a cocktail of medication so that this patient require less narcotic.
Mhm.
So do you know what we do,
I
Michael?
do.
Tell
I
me.
do. So-
When we do our spine surgery and like I did a surgery yesterday, I
Mhm.
put 8 screws, each of them size of my finger in a person, and then poked many holes in them.
Yep.
So is it, first of all, realistic that patient not to be in pain?
No, they
No.
definitely feel pain.
But we have found out that, it's just not about the surgery I do.
Mhm.
It's about that's unrealistic that, this patient doesn't need pain medication. So we give a cocktail of medication to put the patient on the best path to manage the pain so this acute pain doesn't become narcotic. So what do we give our patient usually after our surgeries?
So the first, well, not the first, it's a mix all at the same time, but it's oxycodone.
Well,
It's one of them.
narcotic. We give narcotic. They will need narcotic after our surgery.
And then we do a methylcarbamol.
A muscle
a
relaxant.
muscle relax-
So let's go to categories rather than actual
Yeah,
thing. So we give a narcotic and we give the narcotic, we start at what's safe, and then we go up and down as needed.
and then
Just disregard it. So you guys talk about this pain medication and I come back.
Okay. Dr. Aya, do you want to start talking? Okay. And then one thing that during surgery, for our specific surgery in our cocktail is Toradol, right? Just one dose.
Toradol usually for 24 hours.
Yeah, so a very short course of Toradol, which is non-steroidal anti-inflammatory that kind of similar to ibuprofen and naproxen. So that's a third medication. And then I know that Dr. Abbasi likes to use hydroxyzine for post-operative.
So an anti-anxiety medicine?
Yeah, kind of an anti-anxiety / does kind of a mix of things, but
Yeah, mostly it's hydralazine versus visceral. So the chemical breakdown, changes what it's used for, but he uses it as an anti-anxiety medicine.
So how long do these medications last after surgery?
So that's something that for our pain protocol, we only give for the more intense medications like a narcotic. We only do 7 days at a time, not because we're only going to give them 7 days, but because we like to check back in with them every 7 days before we refill them to see how they're doing. Do they need an alteration in their regimen?
So we talked about the narcotic, we talked about the muscle relaxant,
We talked about Toradol,
Toradol,
a non-steroidal anti-inflammatory.
and that is just where the pain is originated
Mhm.
in the spine, where we poke the hole and put a screw in. And then
because of the side effects of Toradol, it's only a short course right after the
usually a
surgery.
few days.
Yep. And then hydroxyzine was the last one.
So
Visceral.
did you talk about what hydroxyzine is and why we are giving it?
We did.
Anti-anxiety medicine.
Yeah,
So you give it to them so when they wake up, they're feeling more comfortable.
pain modulator. That's all what it
Oh, I
is.
see.
Modulating the perception of pain. Sometimes even we give on top of all of that Neurontin,
Mhm.
but not
Which
all the
is-
time, which is as well a pain modulator, reduces the ability of the pain or all our axons to forward the signal.
That's the gabapentin we were talking.
Yeah.
Oh, I see. Mhm.
And then there's one other one that
Which
I
one?
think that a steroid. So
Local?
I've heard local anesthetic, but I've heard Dr. Kim and you have a little bit of a different process sometimes. He's a big believer in the steroids.
No, I'm a big believer in steroids.
Okay.
And I give it. How do I
Okay.
give the steroids?
Do you give IV?
Yes,
Because
I-
he gives it. Oh, epidural
but
steroid.
you're
I
thinking-
give it exactly where it's needed.
But you're thinking of difference, like we're talking like if they have a post-op complication, that's when Kim would use it
Mhm.
oral peel, right? Or
Mhm.
IV. But Dr. Abbasi uses his as part of the pain protocol.
So let's start with our pain management. That start actually before patient comes to surgery.
Mhm.
We tell them realistically they cannot expect to be pain-free.
Yeah.
That is actually 1/3 of their pain management, setting the expectation. Okay.
Mhm.
Now, we had a patient today who Alyssa got a good testimonial. That patient woke up, the leg pain is gone, he can walk again, smile from ear to ear, and he's still even sassy. But we cannot rely on our patient to be like that. We have to be prepared for the worst and expect, hope for the best, but prepared for the worst. Then in the surgery, obviously, we put local anesthetic in our path. At the end of the surgery, we go to paraspinal muscle where we did all those paths and we numb it up even more. Then I put some steroid and local anesthetic in the epidural space where all those nerve roots are coming together. Before they wake up, we give them Toradol. so that pain receptor, those paths that the pain is generated, is it sort of shut down to some degree. Then they get the narcotic as much as they need. The problem with the narcotic is that you get used to all effect of the narcotic except the suppression of the breathing, respiratory suppression. But all of that is for chronic, not for acute. So one of the criteria to give pain medication is if patient is looking at you saying, I am in pain, talk full sentences, is awake, alert, oriented, you give them pain medication. You wait until that medication has its effect. If they are still in pain, you give more. You can repeat it indefinitely as long as you go these steps. You reevaluate the patient. One of the things I hate to say, and it happens every day, I sit in the hospital, is that the nurses, they call you and they tell you, this patient is in pain. And they push you to give pain medication. And literally, I have seen that. Patient is sleeping, the nurse comes and, hey, wake up, are you in pain? Oh yeah, my pain is 10. And then, no, but
Yeah.
this is almost comical, but it's happening. So if there is a way to go around that. We call that PCA. Michael, what's PCA? Patient
controlled
analgesia. Patient controlled
Oh.
analgesia, PCA. Doctor, explain what PCA is for people who watch this.
It's basically a way that a patient can control their own narcotic schedule.
Within certain limits.
Within certain limits, you put in parameters, you put in the type of narcotic that you want, and it's usually run by IV. And they press a button, and if they are due for another dose, they'll get it. And
But every time they push that, they hear a beep.
they hear a beep.
Have you ever
It's
trained
psychological.
Have you ever trained your dog that you have that clicker?
Pavlov did
That
that.
you give it,
Yeah.
you give things later on, you don't even have to give them a treat. You just have to click.
Yeah.
Okay. Isn't so as a surprise to you that human brain works the same way as a dog's brain? No, it shouldn't. It shouldn't. Okay. Those chemicals are all the same.
Mhm.
Okay. So it's a patient-controlled analgesia, but I don't like that very much because patients sometimes get too comfortable. Every time they're awake, they give themselves another dose,
Mhm.
and that delays their overall healing process because we want them to walk. It's not comfortable, but we want them to walk. With that pump, they sedate themselves, they don't walk as often, and as well, with that pump, it's harder to walk with that pump.
Yeah.
So we don't like that, but one of the things I always say, the PRN, meaning as needed, in medicine, PRN means as needed. So pain medication, PRN, and I put it in apostrophes, I don't put it in my order, for patient's pain, not for nurses' comfort. You know, that is important. You know, we take care of patients in pain.
Mhm.
If you don't want to take care of sick patient in pain, please don't go to hospital. Please don't go to healthcare. If you want to treat only healthy patient,
Go to California.
no,
Yeah, go to-
become a personal trainer.
Or become an
No,
esthetician.
go to
if you wanna-
California.
Yeah,
Everybody there is.
yeah. So
healthiest of the healthy.
if you come to healthcare, expect to take care of sick people, and sicker they are, more they need your help. So again, sometimes you have to be able to, if your child comes to you and cries because every time he wants candy, you wouldn't do that, right? Now, sometimes the safe thing for the patient is not to give them pain medication, but you have to use your judgment. I really hate that scale 1 to 10. What's your pain? Amanda, what's your pain? 10
Yeah.
of 10. Here,
10.
another one. What is your pain? So they need to
But
look
it's
at
also
you.
really relative too.
Always
Because
is.
10
Pain
to
is
you is
always-
way different than
No,
10 to-
yes, true. But pain is truly a reaction, a bodily reaction. Okay. But nevertheless, if you're able to look at me and have a full sentences, converse in full sentences, and you're awake, alert, oriented times 3, in medicine, everybody knows who, and patient says, I am in pain, you can give them pain medication. It's safe to give that. But then don't do it in rapid succession. Just wait and give them again. Now, having done that, so we did in the expectation, in the surgery, we numb it up. At the end of the surgery, we numb up even more and put epidural steroid injection. Before they wake up, we give Toradol. And after the surgery, We give them, based on this, we give them narcotic, but that's not all. We give them still Toradol after the surgery. We give them modulators, including hydroxyzine and obviously muscle relaxant, because we poke through those muscle. Have you guys have muscle cramps?
Oh, yeah.
Okay, so every time you poke a muscle, it's angry. You get some of those muscle spindles, which is scattered through the muscle, and those muscle spindle are going to get the signal, cramp, 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 and so on and so forth. That we break that with muscle relaxant. Now, I just came back from Oman, and I did surgery there, and I hate to say that, even though everybody was impressed with my surgery, it's hard to tell them what I do is just a part of the thing. I just reviewed the pain management of one of my patients in Oman, and I'm about to scratch my head and pull my hair out. I put 8 of those huge screws in that poor person's back, and I looked at the pain regimen of that person, and I really want to hit myself in the head with a hammer.
They don't use this like as much?
No, even though, we disclose to them some of the medication they didn't have, or was sometimes harder for them to get everything we have. But it is not about just what we do. We have to be prepared for our pain management afterward. So we are going to now just make sure from now on that when we do surgery somewhere outside of the United States, that they truly understand it's not about the surgery alone. It has to be aftercare as well. Okay, because one of the things that I tell as well everybody is, Dr. Aya, would you mind to describe burn first grade versus fourth grade? What is the difference?
Oh, it's been a long time since my burn.
Yeah, it has been.
But I will say that the fourth, I thought it was a third degree, but
Fourth is to the bone.
fourth is, it's essentially the difference is when you've gotten the nerves too, right? So if it's painful, it tends to be a better sign.
So I treated fourth degree burn when the Texas City explosion happened in 2002.
Well, you were there.
I was there.
There's a plaque now, from that.
Yeah, I treated those patients. In the middle of the night, they came all to us. Many of them came. We couldn't accept them all.
Yeah.
I had patient that, the burn was to the bone, but it's not just a burn, it's just the whole skin has become like a leather, and it's contracting everything. There is a so-called burn table. It is very similar to when they do autopsies, by pathologies. And we took a 2-inch blade on a patient who still was awake. Surprisingly, some of them were awake. With no anesthesia, we went on the bone with the blade and slit it on 2 or 3 or 4 places, depending on the compartment, and opened the compartment, the release of the compartments. We did not anesthetize them. Why?
Because their nerves were destroyed.
The nerves are destroyed. The fourth degree burn is analgesic. It's that you have no pain. What's the most painful burn? First degree or fourth degree? First degree, because all the apparatus to feel the pain is there, and it says, this is wrong. This is just, do something about it, okay? So in our surgery, we cause the least amount of damage. There is a spine surgery. Dr. Arya, do you know what's aquamantis?
I open posterior surgeries. We love our aquamantis.
You love your aquamantis. Explain what that is.
It's a device that heats up the water and use it to.
No, it doesn't heat up the water. It heats up everything.
Yeah, but use it to like cauterize the tissue.
It uses 120 volt bipolar, literally with a penetration of 1.5 centimeter. It literally cooks your tissue to stop the bleeding. And it does stop the bleeding. Bleeding stops, but you create to a depth of 1.5 centimeter burned, cooked tissue. This patient wake up initially without pain, but do you know what's the risk of infection with aquamantis? 8 to 10%, because you create that tissue. Whereas our risk of infection is 0.3 because I don't even use regular bipolar. Now, so our patient, if you're not prepared, they wake up with a grade 1 burn, which is they recover the fastest from. The next day they are different, but if you're not prepared, it can be painful for them. So be prepared for what you do. Now, I'm going to take this off and talk about a little more about the pain management, okay? So tell me, let's talk about the chronic pain, Dr. Aya. We did all of that and so on, and some people will end up with chronic pain. What are current, what do you suggest, or what are current treatment, other alternatives to the chronic narcotic for chronic pain? What else can we do for them?
I think there's more and more literature on like cognitive
Certainly,
yeah.
certainly. Now, those psychological
reprogramming the
support
brain.
and so on and so forth, which is practically an internal modulation of the pain.
Right.
What else?
Injections, physical therapy.
Many times, if they are chronic pain, they have done it, they have been there. It's really, they passed that already.
In Minnesota, medical marijuana is legal for chronic pain.
Here you are. That is as well a pain modulator. Works very well, actually. And by the way, it is less dangerous than any narcotic that we give. What about some procedures to manage the pain?
Where's the pain? In the back, spine?
Yeah, in the spine, in the legs and arms.
You talked
Wherever.
about that brain thing.
We talked about those. Those are not widely accepted yet. There are people do that, even stimulations in the subgenual part of single gyrus, but they're not widely accepted. But things that are happening in United every day procedure that people get for pain management.
Ablations.
That as well can be a good option if the source of the pain is outside, for burning those nerves, radio frequency ablation, like you burn nerve coming, certain part is just causing you pain, you go and burn those nerves. I'm talking about more.
Acupuncture.
Certainly.
Trigger point injections. We do
Trigger
those
point
here.
injection, yeah. What else?
A
A little more surgery heavy. That
Okay.
I know you know about
like
that.
Fusions.
No, I'm not talking about
spinal cord
the
stimulator.
spinal cord simulations. Yeah. Can you describe what they are, Dr. Aya?
So it's neuromodulating, but on an anatomical level.
Go ahead.
basically.
Yeah,
So,
excellently said.
a
So
pain provider, so it could be a spine surgeon, very infrequently, but mostly pain doctors. They put in this device that sends pulses into, it's usually in the thoracic spine and sometimes in the cervical spine, but it essentially tricks your brain or changes the perception of pain.
do you remember we talked about pain is a signal, is a sensory? Like maybe that cable that take the signal from the camera to the computer. It's a very specific signal. Imagine you take that cable that takes the signal from the camera to the computer and you put 120 volt electricity on that. You prevent for the signal to pass through. That's what spinal cord stimulation device are. You give certain kind of energy, how much higher level to spinal cord, to the back part of the spinal cord where the signals are passing through, and you're preventing the pain signal to pass through. And for some reason, over lots of trial and error, we found out certain kind of signals work best on those pain signals without affecting too much other signals. Still, they affect some other signals. Some people do get some numbness in the same area and so on. And we know that can be a very effective way of managing the pain. How effective, depending on the patient, and obviously nothing is 100%, everything has side effect and so on and so forth, but that can be a very valid way of treating the pain. There's another procedure that is very commonly performed, and as well to address the central pain we haven't talked about. It's a combination of medication and procedure.
The baclofen pumps or the pain pumps?
Pain pumps as general, not only baclofen pump, but pain pumps. They can be practically, Mike, do you know what they are?
Not really. I've read through a lot of charts of people that have them, but I don't really know what they are.
What are they?
Pumps that essentially pump pain medicines, different types, into the epidural space, and they're able to provide pain control.
Epidural space?
The epidural.
Is it the epidural or a spinal pain pumps? The
It's right in the
catheter,
CSF.
yeah, the catheter is right
I
in
thought
the.
Schultz said it's in the epidural space, like it's
No.
an epidural that just lasts
I
forever.
guarantee you it's not. It is
Oh,
in the
okay.
CSF space.
How big are these pumps?
Now, the pump is maybe the size of this mouse. That can be big because they go every few months, they fill inside. They have a catheter that goes from practically under the skin, which where the pump is.
It stays in the body?
Yeah, that pump stays in the body. And then the catheter goes all the way inside of our spinal canal into the intradural space, not epidural space, this epidural in the subdural space, in the CSF space, and give that medication, which is concentrated in minute dose. The problem with the pain medication that you take as a pill is that 99% of it goes everywhere in your body. Only small fraction goes where it's needed. Whereas this pump, they put the medication exactly where it's needed. Did you get this the spinal block when you had your
Yeah,
childbirth?
didn't work, but I tried.
Did not work,
No,
but
it did not work.
but generally they work because you go inside of the spinal canal and you give the medication right there. Then you practically they paralyze you from base
Face
down,
down, yeah.
but then you don't feel that. Now here the medication is narcotic, but sometimes we give as well like lidocaine or other medication, but in such a minute amount that is more effective for those pain medication than for any pain pathway than anything else. As a matter of fact, Dr. Schultz, I'm really he's an expert on that.
Yeah.
Says that they can give this patient lidocaine even higher up that we are scared of giving, because if you don't give it the right amount or wrong amount, they quit breathing.
Yeah.
But in the right amount, they become so functional. Even people with cancer and chronic pain
That's
and
good.
palliative and so on. It really works, but it's a high science. How to dosage that putting it in is not really big science. As a matter of fact, I want to teach you to do that.
Me?
Yes, you put a two. Did you hear that?
We'll
So,
talk.
You take a 14 gauge 2E needle, you put it inside of the dural space, you path the catheter in.
So the spinal cord, it's like I went to the lab, yeah, but into no.
Yeah.
No. We'll talk.
I'm going to do I'm going to do an intradural tumor.
Oh,
Once
cool.
you know how it is, you should scrub in.
Mhm.
It's not a big deal. It's just,
Says the neurosurgeon.
yeah, well, so, but that can be very effective because you give minute amount of medication exactly where it's needed. So I'm running out of saliva to talk more. So because I did most of the talking,
You're the one with all the knowledge.
Oh,
no.
For pain, not all.
oh.
No, not all. I would be scared if I was the only person with all the knowledge. But no, let's talk. Maybe if people have questions, if you guys have questions, let's answer a few questions. What do you think?
Melissa?
Yeah, we don't have any questions in here, but I have a question.
Yeah.
How much, when you talked about giving anxiety medicine before the surgery, how much is pain connected to, or how much can anxiety like exacerbate pain?
A lot.
I know that, but I was
You're like, you don't have to tell me.
just curious because I went through a couple surgeries and that's something that they never gave me, but I know I probably would have benefited from the anxiety of a surgery in general, let alone the pain part of it.
Yeah. So now that you know how anxiety aggravates the pain, imagine you go to a patient's room and you come as confident, at least you appear, you know what you're doing, versus you go there, you don't make eye contact, you just look away and answer the question in a way that it makes it very clear you are not comfortable with what you are doing. So what do you think, which patient is going to have more anxiety and more pain.
I would 100% would rather have someone convince me that they know what they're doing than somebody know what they're doing.
No, there are good data
Scared
about that.
about me.
There are good data about that. So don't ever scare the patient. Even the scariest situation, reassure the patient. Not lying. This is not lying, but reassure the patient about the situation that even in the worst situation, you know your shit. You know what you're doing.
Yeah.
If you go in a place and you appear, you don't know what you're doing, even if you know what you're doing, you're going to aggravate patient's situation. And it's not only pain. It is everything else attached to that. I'm going to recite you a study that was done many, many years ago, where they showed people, first they have a questionnaire, and then people filled their status, psychological status, and they divided them in roughly optimist and pessimist, maybe for that day, I don't know, but they divided them that. Then they showed them a short movie with the open end, and then had another questionnaire, and they asked them how do the movies or the video is going to end? What's the end of it? Obviously, statistically, very significantly, the pessimist, they thought the main person will die or something bad will happen, and the optimist they decided that it's going to be well. It was open-ended. It could go both ways, but that did not end it there. They checked their immune factors in their blood after the movie and before.
Mhm.
The optimist had higher, the pessimist had lower immune factors.
That's why I drink turmeric tea.
But do you understand
Making up for the best.
do you understand the extent of what that really means? Michael, what that means? Just a movie, open-ended movie, made immune factors in some people go higher and in some people go lower.
Yeah.
What is the biological consequence of that?
So stress increases cortisol, you increase tissue damage, you're not going to heal as well, your blood sugar will go up, you'll feel
Infection.
risk of infection, you'll put on long-term, you put
Fighting
on
the
weight.
cancer.
Yeah,
Fighting the cancer.
everything.
So if anybody says, that you can't get the mind over matter, that is the closest we come to it, meaning that truly, if you truly believe you are going to fight it and you'll be all right, statistically, you will have higher immune factors, and statistically, you're going to beat it more than if you already have. Now, it's a common thing that people know that when a partner dies, older pair, if one dies, the other one dies within few weeks because they completely give up. Then they succumb to the simplest infection that we always have, and so on. So this is the closest we come to prove that his mind is truly over matter. Okay? So when you treat your patient, understand that your behavior as well impact that.
They always taught us for patient care when I went to school, it's not always what you say, it's how you say it. And that always sticks with me. Is that, having a smile, having that, like you described, having that positive attitude goes a long ways.
One of my examples is during school is I had a preceptor who I multiple times saw she had no idea what she was doing, and she told people the wrong thing, but she did it confidently every time, and patients loved her and had no idea that she was wrong. So
it can happen as well.
It was an interesting example of how far confidence can get you.
Well, it's not just healing too. If you're a waitress and you are nice about a mistake,
Mhm.
you get away with it a lot more than if you're like
You get more
sassy about
tip.
it. Yeah.
Yeah.
If you're confident and you're like, oh my gosh, I'm so sorry I messed that up, they actually do tip you more.
Yeah, here you are. So I'm coming back that the interpersonal, from pain to interpersonal. Any other question before we close the meeting here, our podcast today?
Not from our side.
Okay, well, I think that was really very comprehensive and we covered everything.
Very informative. for sure.
Excellent. Well, thank you so much for joining us.
Thanks, guys.
For Essence, I'm Dr. Abbasi.
I'm Amanda Armagos.
I'm Mike Yeager.
Dr. Aya.